Hello, my name is Jennifer Higa, and I'm the Advanced Endoscopy Fellow at Virginia Mason Medical Center in Seattle, Washington. On behalf of my co-authors, I would like to thank Gastrointestinal Endoscopy for the opportunity to discuss our recently accepted manuscript entitled Optimizing Duodenoscope Reprocessing, Rigorous Assessment of a Culture and Quarantine Protocol. The senior author on the manuscript is Dr. Andrew Ross, who is the section head of the Division of Gastroenterology at Virginia Mason Medical Center. In response to a duodenoscope-associated outbreak of multi-drug-resistant E. coli, the medical center implemented a endoscope culture and quarantine protocol in February 2014. Briefly, the culture and quarantine protocol involves per-use culturing of all endoscopes following reprocessing. These endoscopes feature a cantilevered elevator mechanism, which has been proven in other studies to serve as a nidus for bacterial transmission. Standard reprocessing includes enzymatic pre-cleaning, followed by manual cleaning, and then high-level disinfection using an automated endoscope reprocessor. Following reprocessing, the endoscopes are cultured using a modified sampling protocol designed by the Centers for Disease Control, and then quarantined for 48 hours until their cultures are demonstrated negative for pathogenic organisms, also defined by the CDC. If the cultures are positive, they're reprocessed until cultures are negative and then re-quarantined. In order to accommodate the quarantine process, the medical center purchased 20 additional duodenoscopes and increased microbiology lab staffing. Our group has previously published a 1.9% high-level disinfection defect rate based on the first year of data following implementation of the protocol. The recently accepted manuscript includes an analysis of over 4,300 cultures in the first 3 years following implementation of the protocol. The aim of the study was to evaluate the individual impact of different interventions that were made during the study period on the duodenoscope culture rate. In other words, what were the meaningful changes made during the study period that impacted the rate of positive culturing? In total, 33 of 4,307 cultures were positive for high concern organisms during the study period, resulting in a 0.697% high-level disinfection defect rate. Per-use culturing of all duodenoscopes successfully identified 2 culprit instruments that serially cultured positive and were subsequently withdrawn from service. Withdrawal of scope named A was found to significantly impact the culture rate. Withdrawal of scope named B did not. The second significant intervention included manufacturer-recommended changes to the manual cleaning process. These included additional flushing of the elevator mechanism and implementation of a new cleaning brush designed to better address the elevator recess. In summary, our study demonstrates that a per-use culture and quarantine protocol successfully identifies culprit endoscopes. Withdrawal of one of these endoscopes significantly impacted our positive culture rate. Our findings additionally reinforce the need for a robust manual cleaning process. The study was important to perform for a few reasons. It's important to remember that duodenoscope culture positivity is not a direct correlate of infectivity. Rather, in this situation, is used as a metric for adequate endoscope reprocessing. Additionally, duodenoscope reprocessing remains an issue for all centers that perform ERCP, large or small. The magnitude of the problem is difficult to even measure without formal surveillance programs in place. Even then, the sensitivity of endoscope cultures remains unknown. Available enhanced reprocessing and surveillance strategies like culture and quarantine need to be tested rigorously to determine cost-effective and efficacious interventions. Efforts should be made to formally evaluate the impact of these process improvements on clinical outcomes. We hope that these findings contribute to the conversation about enhancing safety of ERCP for our patients. We believe that infectious risk from scope transmission is mitigable if we have appropriate safety and quality checks in place. Future work is needed to refine a practical and cost-effective solution that works for all centers that perform ERCP. Thank you for your time, and we hope you enjoy reading our article.